Can you hear me in the back? Awesome. Okay. Happy Thanksgiving, everyone. Hope you get to enjoy some good food and some good time with some people that you care about, maybe, hopefully. We're going to rock through 3, 4, 5, and 6 today. I'll give you a break probably halfway through, and I'm hoping it doesn't take 2 hours. But hopefully it'll only take an hour and a half, I hope. Okay, so let's go. So, number 3, name. Good. Motor sets for your boat. Motor. What fiber types? Good. Let's talk about those for a second. All right, what are they all doing? So GBEs, we briefly touched on this. So these are parasympathetics whose preganglionic cell bodies are where? Good. Parasympathetic preganglionic cell bodies in the Edinger-Westphal nucleus. Okay. They are going to synapse where? Perfect. Okay. They're going to go synapse on the ciliary ganglia. Then postganglionic fibers from there are going to their targets. The targets that you need to know, they are going to the ciliary muscle, and they are going to the constrictor pupillae. I can spell it right. You might also see the constrictor pupillae called the sphincter pupillae muscle. It's the same thing. So that's GBEs in a nutshell. So y'all can kind of like hear me breathing, which is kind of creepy because it's so close to my mouth. So sorry. So that's GBEs, GSEs. So what do GSEs do just generally? Broad concept. Motor to skeletal muscle. Good. So this is motor innervation to 5 of the 7 extraocular muscles. Okay. The caveat are the 2 that it does not do. It does not do the superior oblique, and it does not do the lateral rectus. The superior oblique is done by which cranial nerve? Good. And the lateral rectus is done by 6. Some people will remember the little phrase SO4 and LR6. Y'all don't remember. So that means that oculomotor is doing the other 5. So that is the inferior oblique, superior rectus, inferior rectus, medial rectus, and then the last one is your levator palpebrae superioris. Again, it's motor to the inferior oblique, your other 3 recti besides this one, so that's superior, inferior, and middle, and then the levator palpebrae superioris. Yes?
Did you say it was trigeminal, the superior oblique?
No, 4.
Okay.
Yeah, 4, not 5. So trochlear. If I said trigeminal, I misspoke. It's trochlear. what these fibers are doing. What's the foramen that they're going through?
Superior orbital fissure.
Good. Superior orbital fissure. So we're going to walk through it, okay? So we've got two sets of fiber types. That means we've got two nuclei. You've got the Edinger Westfall, which is going to house your GVEs, and then you've got the oculomotor nucleus. The oculomotor nucleus is going to house your GSEs. So these are where the cell bodies of each of these fiber types live. Okay? So they are going to both send fibers out into one nerve. Right? When it leaves the brainstem, it's one nerve. That one nerve is when it leaves, it's going to pass through the posterior cerebral and superior cerebellar arteries. So that's like your landmark. It's going to course through the cavernous sinus, and then it's going to exit the superior orbital fissure. Yes?
What's the artery thing?
Your posterior cerebral and your superior cerebellar. Okay? It's going to leave the superior orbital fissure, and then it's going to branch into two different divisions. Okay. So your two divisions are the superior and inferior. Okay, so let's talk about those fibers. So I'm using purple. I don't know if you'll be able to see it. Purple is going to be our GSEs. So our GSEs are going to leave the oculomotor nucleus, and they're going to go into the nerve, and they're going to do everything it's doing. Some of them are going to go in the superior division, and some of them are going in the inferior division. The superior division is going to feed your superior rectus and your levator palpebrae superioris muscles. Again, the GSEs in the superior division are going to feed your superior rectus and your levator palpebrae superioris. The ones in your inferior division are going to pick up your others. They're going to pick up your medial rectus, your inferior rectus, and your inferior oblique. We all dissected the eye out in lab? Okay, good. So those fiber types are going directly to those muscles, and they are innervating those muscles and causing them to do their function. Okay? GVEs from your Edinger Westfall. They're going to follow the nerve, and And then they are only going to go in the inferior division. They are going to synapse on what? Good. The ciliary ganglia. Beautiful. It does. Don't worry about the tiny little details. So the ciliary ganglia is right beside one of the branches of the inferior oblique, and it just moves from one to the other. Don't worry about exactly what it's doing. I just did that out of ease of showing you where it is. So from the inferior division of the oculomotor nerve, those fibers are going to synapse on the ciliary ganglia. Do you remember last time we met I told you that all post-ganglionic parasympathetics, those fibers, travel on what to get to their target? A branch of the trigeminal nerve. That's exactly right. The branch that this is using is a branch that is connected to the ciliary ganglia. And they are called the short ciliary nerves. That is a branch of V1, the first division of the trigeminal. Those postganglionics that leave the ciliary ganglia are going to ride the short ciliary nerves to get to their targets. Remember what their targets are. They are the constrictor pupillae and the ciliary muscle. So postganglionics are hopping on this branch of cranial nerve 5 to get to their target. Remember, they are not part of cranial nerve 5, right? They're just riding it to get to their target. So let's talk about those targets. Constrictor pupillae, it does exactly what it sounds like it does. You might also see it called the sphincter pupillae. Its job is to constrict the pupil. It makes the pupil smaller. The clinical term for a small pupil is called miosis, M-I-O-S-I-S. So the constrictor pupillae is innervated by parasympathetics whose function are to make the pupil smaller. We'll talk about why in just a second. Okay? The other target is the ciliary muscle. So let me see if I can do my best to explain this to you. So this is part of an eyeball, and we've taken the eyeball and we've cut the top off of it, and we're looking at the inside of it. Okay? So this is the front of the eyeball. This is like the pupil, the anterior chamber. And we've cut it in half and we've turned it on its side and we're looking at it. Okay? So right here are these tiny little muscles called the ciliary muscles. They function to control the diameter of the lens, which is situated right behind the pupil. So what happens is that ciliary muscle is suspended to that lens by the suspensory ligaments. Have y'all done this in histo? Y'all haven't? Okay, you will. You'll look at it under the microscope and you'll have to learn all the parts of it and everything like that. So the ciliary muscle is suspended to the lens by these fibers that are called the suspensory ligaments of the lens. They're also called the zonulus something fancy. Suspensory ligament, that's all you need to know. At rest, so when these muscles are at rest, these ligaments are pulled tight. So it really probably looks more like this. So when this muscle is at rest, these ligaments are pulled tight. So the lens is like a little elastic ball of goo. And think of like the little bouncy balls you used to get out of like the gum machine when you were little. Right? So those want to stay in a circle. Right? And you can push them really, really hard and kind of flatten them out a little bit. But as soon as you let off pressure, they're going to ball back up. Right? Think about the lens as doing the exact same thing. So when these ligaments are tight, it's pulling on the corners of that lens and kind of making it like a pancake. Okay, so it's flattening out the lens. When the ciliary muscle contracts, it actually allows these fibers to loosen their grip, so they're not pulling tight anymore. So when these muscles contract, these fibers loosen, and because the lens is elastic, it wants to be a ball. So when these muscles contract, the fibers loosen, and the lens balls up. Does that make sense? I'm going to say it again because sometimes people have a hard time with that. At rest, those fibers are tight and they pull the lens flat like a pancake. When the ciliary muscle contracts, it allows those fibers to become loose. When those fibers loosen, the lens balls itself up into a ball. The term that we use for that is increasing the AP diameter of the lens. So what I mean by that is this is anterior and this is posterior. So doesn't it make sense to you that when the lens balls up, the distance between here and here is greater? Does that make sense to everybody? Than the distance between here and here when it's spin like a pancake. So when the ciliary muscle contracts, the AP diameter of the lens increases. That's what that means when you read that. Does that make sense to everybody? Okay, good. So parasympathetic fibers are responsible for increasing the AP diameter of the lens. Okay. This all has an important function. I promise I'm getting there. Okay. Okay, so why is that important clinically? There's a few clinical things you need to know about cranial nerve 3. Let's talk about near vision first, since that's kind of the topic that we're in. Okay, so near vision. This is what happens when you read something up close. So like it is not a normal function of your eyes or your brain to be able to interpret something that is close to you. And I'll explain to you why. For you to be able to see near vision, 3 things have to happen. The first one is that both of your medial recti have to contract. So why is that significant? Can you make, at the same time, any other extraocular muscles move in the same direction? Right? Like you can't make your lateral recti go like this. You can't make your eyes go like this. You can't make one eye go this way and the other eye go that way, right? That just doesn't happen. Okay? So that's called disconjugate movement. This is the only time where disconjugate movement happens. That's weird, right? That's why it's special. It has to happen for you to be able to see near vision. So your medial recti contract, so your eyes move opposite to each other. They both move in on your nose. Kind of like when you were little and you used to try to like cross your eyes. Okay, the other thing that has to happen is you have to constrict your pupil. So your pupil here is what changes the amount of light that enters to the lens. So your pupil protects your eye from getting too much bright light, and it changes the amount of light that the lens has to change. And I'll explain that again in a second. The third thing that happens is you increase the AP diameter of the lens. Your ciliary muscles contract. So that, let's see if I can explain that to you. Because if I finish drawing this eyeball up here like this, the lens function is changing whether the light goes like this on the retina or whether the light goes like this on the retina. Okay, so it changes the amount of light you're letting to the back of the retina. So for you to be able to concentrate all of that light on the fovea, which is what we talked about last time, which has the best vision of the whole eye, right? You need all three of these things to happen. Two of them are parasympathetic responses, right? If you lose your parasympathetics, you lose the ability to read near vision. That makes sense, right? You can't change the diameter of the lens if you don't have parasympathetic input, and you can't protect your pupil. You can't constrict your pupil. So if you lose parasympathetics, you lose near vision. You cannot read up close. So that's one thing. The next thing that I want you to know is posterior communicating artery aneurysm. So in the course of the nerve, it actually passes right beside the posterior communicating artery. So if an aneurysm is just kind of like an outpouching of an arterial wall. So that's like a weak spot in the wall of the artery where the blood kind of causes it to balloon out. Okay? If it's ballooning out and pressing on that nerve, it's pressing on the fibers that are traveling within that nerve. Does that make sense, right? We kind of talked about that when we talked about cranial nerve 1, if you have like a tumor. It's the same concept. Why this is a little bit different is because if you take the nerve itself and you cut it into the way that the fibers are arranged in the inside of the nerve, your GVEs are on the outside of the nerve. Okay? So your parasympathetic fibers are the most peripheral inside the nerve. So does it make sense to you if you've got a compression injury, if you've got something that's pushing against that nerve, and you're putting pressure on the fibers running in that nerve, the ones you would lose first are GVEs. Does that make sense? So a compression injury always is going to lose your GVEs first. The most common one is an aneurysm. The one that you probably will get tested on is a posterior communicating artery. But you can have any of them. You can have your posterior cerebral, your superior cerebellar, any of them. Okay? So a common clinical question is going to be an arterial aneurysm that's pressing on the fiber, and it's going to want you to know what that patient looks like. I just told you what it looks like. So they can't do what? So they've lost near vision, and if you've lost your constrictor pupillae, then you have unopposed action of what? The sympathetics, your dilator pupillae. Okay? So if you have unopposed action of your sympathetics, that pupil is going to be really big. Okay? There's a word for that. Mydriasis. So mydriasis is a big pupil. I don't know if this helps you, but the difference between mydriasis and meiosis. Meiosis is a smaller word. It can fit inside a small pupil. That's how I remember it. Okay. So a compression injury loses GVEs first. That patient loses near vision, and they have a dilated pupil on that side because of unopposed action of your sympathetics. Okay, everybody with me? So every once in a while, when we talk about strokes especially, stroke patterns affect certain areas in the brainstem. You do not have to know the particular areas. You'll learn them all when you get to neuro. But certain parts of the brainstem are fed by certain arterial supply. So you can knock out a very particular artery that feeds the brainstem, and you'll only lose the nuclei that are fed by that artery. Okay? An interesting thing that can happen is these nuclei are fed by different arterial supply. So sometimes you can have a stroke that affects just your GSEs because they're different blood supplies. So we've already talked about what it would look like if it was GVE. So let's talk about what it looks like if it's just GSEs. Okay? So now you've lost 5 of the 7 extraocular muscles, right? So now you have unopposed action of the other 2. So what does that look like? That patient's eye is going to look down and out because you have unopposed actions of the lateral rectus and the superior oblique. Even though superior is superior, it actually depresses. People get confused about that. So this eye that has lost purely GSEs, it looks down and out. Your pupil still works just fine, right? You can, if you shine a light in there, it'll still constrict because your GVEs are fine. Okay? So your pupil works fine. Your eye's just stuck down and out. Another interesting thing about it is when you lose your levator palpebrae superioris, do y'all know what that muscle does? It prevents what we call lid lag, right? So like when you look up to the ceiling, if your levator palpebrae superioris did not work, when you looked up to the ceiling, you would be looking at the back of your eyelid. Right? So you don't think to lift your eyelid. It just moves when you look up. Okay? So if you lose your levator palpebrae superioris, you have lid lag. So your eye is moving, but your lid is lagging behind the movement of your eye. So like literally you'll just be looking at the back of your lid. Okay? It's not super noticeable because all they can really do is look down and out. Okay? but just know that that's what would happen if you lost that muscle. All right. So we talked very briefly about this. So sympathetics are doing this, right? So your sympathetics are going to your dilator pupillae. Okay? They are getting there. How? I told you yesterday. How are sympathetics getting to their target in the head? Yes, arterial routes. So they are riding branches of the internal carotid artery. So they're riding the internal carotid artery to the ophthalmic artery, which is going to the eye. And then they ride the ophthalmic artery as far as they can, and then they actually hop off of the ophthalmic and hop on a branch of cranial nerve 5. It's called the long ciliary nerve. So parasympathetics use the short ciliary, sympathetics use the long ciliary. It's a little bit of crossover, but you do not have to know that. Okay? For the most part, sympathetics use long, parasympathetics use short ciliary. Its purpose in the eye is to dilate the pupil. Okay? The other thing it does in the eye is it does the superior tarsal muscle. It's this tiny little muscle that's embedded on the inside of the eyelid that helps to keep the eyelid erect. So it keeps the eyelid open. Okay? It's not a big chunky muscle that you can grab a hold to like you can the other extraocular muscles. It's actually embedded in the eyelid itself. And it's under autonomic control to keep the eyes open. Think about it. You don't walk around all day keeping your eyes open. Right? Because it's an autonomic function. Okay? So, let's talk about what it looks like when you lose it. We've already talked about this. We talked about it for the very first test that you ever took. It's called Horner syndrome. We talked about it for the first test, and we talked about it for thorax. So Horner syndrome, it is interruption of the sympathetics getting up to the head. A very common question, like STEM, that you'll have is a Pancoast tumor. So that's a tumor in the apex of the lung, right up here at the top of the lung. And it erodes into your cervical ganglia. Because remember, that's where your sympathetics are going. They're going up that chain to those cervical ganglia. If you interrupt that route and you cut them off and they can't get to the head, you've lost sympathetic input on that side of the face. So if you've got a tumor or whatever on the right side, you lose sympathetic input to the right side. And on the right side, you've lost this. You've lost your dilator pupillae. So you have unopposed action of your parasympathetics. So that pupil is going to be what? Small. It's going to be a really small pupil. Unopposed action of parasympathetics who are constricting the pupil. So you've got meiosis. Along with meiosis, you've also lost your input to the superior tarsal muscle. So now your lid droops. That's called ptosis. P-T-O-S-I-S. Meiosis and ptosis. Do you remember I told you everywhere in the body and the skin, you've got sympathetic input that's going to your glands and your hair follicles and all that? And your blood vessels that live underneath the skin. Okay?
You said the ptosis was just nature?
Yeah, ptosis is just a droopy lid. Because you've lost the superior tarsal muscle. You've also got flushing. Because you've lost your sympathetic control over your capillary beds in the face. So all the blood is like brought up to the face. So that side of the face is flush, it's bright red. And you've lost the input to your sweat glands. So it's a dry face. We call that anhidrosis. Hydro, water, and no water. That's fine. Yeah.
What's the difference between the superior tarsal muscle and the levator palpebrae superior?
Okay. The levator palpebrae superioris, its function is to move the eyelid with the motion of the superior rectus. So like when your extraocular muscles move and it moves the eyeball up, your levator palpebrae superioris moves the lid with the motion of the eye. Your superior tarsal just keeps the lid wide open. It doesn't have anything to do with the movement of the extraocular muscles. It just keeps your lid right open. So like if you don't have it, your top lid will actually just droop down. It won't move at all with the motion of the eye. Like, that's a bad way to say it. It will still move with the motion of the eye if your levator palpebrae superioris is okay. So it'll still move up when you look up. It'll just lag. It'll just be like droopy. Yeah.
But then you also have the orbicularis oris below. That also helps open the eyes?
Yes, that opens the eye on command. So that's your ability to go like to open your eyes and make them bright. That's you control that muscle. Mm-hmm. So the 4 things you see with Werner syndrome, which is interruption of the sympathetics to that side of the face.
So if you damaged your levator palpebrae, is your whole lip be closed?
No, your superior tarsal's fine. Your lid will be open. It just won't move when you move your eye. If you lose your levator palpebrae superioris, yes, your lid will be open because your superior tarsal muscle is going to keep it open. But when you lift your eye up, you're going to be looking at the back of your eyelid. Because your eyelid won't move. Because your levator palpebrae superioris doesn't work.
Can you use the drooping of the eyelid as a measure of sympathetic tone?
You can.
Okay, so is that what I measure? Like, whenever I'm going over, my eyes tend to droop.
That's awesome. Yes, it's the same thing when you're sleepy. So when you get really, really sleepy and you have an overwhelming parasympathetic response to shut down and go to sleep, that's why your eyes start to close. You start to lose that sympathetic control to keep them open. Awesome. Okay. Okay, the other thing is testing. All right, testing. Let's talk about the difference between me and most of you in this room.
You're back there.
No, none of that. Is that I personally did not learn this. I was like, whatever, I'll be okay missing that. If you are someone who really wants to learn everything, knock yourself out. There's a chart in your book that goes through every single muscle of the eye, how it moves, the direction that it moves, and how you test it. You're probably going to have a question on it. You have at least one every year. It's a big chart. I was totally okay attempting to guess and get it right and missing it if I didn't. But if you're really gung-ho about learning everything, by all means, refer to that chart in your book.
Is there anything they prefer? Like, is there one muscle in particular for to learn one?
No. If I were you, I would learn your, if you're just going to learn 1 or 2, I would learn your obliques because the others are pretty much self-explanatory. Like your recti only move in one direction. So you can pretty much figure out how to test them if you isolate the muscle and move it in that direction. But your obliques are very different because it moves opposite to what you think. So if you were going to memorize one thing, I would memorize your superior and inferior obliques.
Yeah, I was just going to say, I had a trouble studying this a couple of, I don't know when this was, but that picture with the arrows, if you use the picture with the arrows, you don't even have to memorize the chart, because you can take that picture, learn the arrows, and then for the test, do like a different arrow for all of them, and then all you have to do is draw an eye on your scratch paper, and then do the arrows for the muscle movements, and then the arrows for the test.
There you go.
That works.
It's easy to YouTube a video too. Like you can YouTube a video of someone testing them all, and it might help you better to see it than to try to memorize a picture. However you want to. Or you can be like me and be like, yeah, it's fun. Okay.
You gotta take some somewhere anyway.
Okay.
No.
Important, way more important than the directions that your eye moves, unless you want to be an ophthalmologist, is the pupillary light reflex. I use this all the time. I use it when I pronounce someone dead. I use it when I evaluate someone who's comatose. I use it when I do a full neuro exam. I use it all the time. I probably use it every single time that I work and when I evaluate a patient. Okay, so what is it doing? So we mentioned it briefly last time when we talked about the optic nerve. So cranial nerve 2 is your sensory limb, and cranial nerve 3 is your motor limb. So, let's see. Okay. So, let's take a flashlight. And let's shine it in the right eye. Okay. The right eye perceives the light with cranial nerve 2. Okay? So the sensation is the perception of light. It's vision. Okay? So cranial nerve 2 is the sensory limb. It perceives the light. The reflex is that cranial nerve 2 talks to cranial nerve 3 in both eyes and causes the pupils in both eyes to constrict. So cranial nerve 3 is the motor limb, and it is the constriction of the pupils in response to the bright light, right? You're trying to protect the limbs from that overwhelming amount of light, and you're protecting the back of the retina from all of that light. So cranial nerve 2 picks up the sensation of light, the bright light in your eye, and it talks to cranial nerve 3 on both sides. So the right cranial nerve 2 talks to both cranial nerves 3 and says, constrict the pupil. That is a normal response. So that's why when you go to the doctor and they shine the light in one eye, they look at that eye, they shine it in the other eye, they look at that eye, and then they do it again, and on the second time they're looking at the opposite eye. So you're shining it in this eye, but now they're looking at this one. Shine it in this one, and now they're looking at this one. Okay, so it's the swinging flashlight test is what we call it. Okay? So let's talk about how that is significant. So what if I take a patient and I tell you that I shone the light in the right eye and the right pupil constricted, but the left pupil didn't? Where is the deficit? Left cranial nerve 3. Right? Because if the right cranial nerve 3 worked, that means that 2 picked it up correctly and told it to contract. But the deficit is over here because it did not contract. Okay, does that make sense? Okay. What if I shone the light in the right eye and nothing happens? Are you sure it's cranial nerve 2? Oh, you don't know. So now, trigger. Okay, so now you have to shine it over here. So what if I tell you that I shine it in the right eye and nothing happens, but I shine it in the left eye and both pupils constrict? Where's the deficit? Cranial nerve 2 on the right. Okay, does that make sense how you figure that out? Okay, it can get a lot more complicated than that. No one is going to trick you. Okay, it's going to be that simple. It's going to be that you understand that one eye picks up the sensation and both eyes should respond appropriately. Okay, that's as deep as you have to go. But does that make sense? Okay. All right, let's move on to 4. nerve 4 and cranial nerve 6 are really fast. Thanks the Lord. Okay, so cranial nerve 4, name, motor sensory mode, fibers, whoa, huh?
Whatever you write.
GSE. Foramen, superior orbital fissure. We'll do clinical and testing at the end. All right, GSEs. What are they doing? This is motor innervation to what? Good. And it's that simple. It's motor innervation to the superior oblique. Okay.
It don't take too long. You don't get no double shit.
Okay. Okay. So, what? It's actually really straightforward, really simple. Okay, so a couple of caveats that you need to know about it is the only cranial nerve that emerges dorsally from the brainstem. Everyone else comes out from the front. But the trochlear nerve comes out from the back of the brainstem and wraps around and goes forward. So it's the only dorsally emerging cranial nerve.
So, how does it wrap? It comes out of the back and then it goes around the whole brain? Or?
No. It just wraps around the brain stem. So it comes out the back and it just wraps around the edge and comes forward. So like if I'm facing, I don't know how to explain this. If I'm facing forward towards you, and let's say I had a tail, like a cat, I could take my tail, which is coming out the dorsal aspect of my body, and wrap it around the front and point it at you, right? It's the exact same thing. That's all I can come up with, okay? What now?
There's another nerve off the back that's just like going straight back.
There are some that emerge dorsally. This is the only cranial nerve that emerges dorsally. Yes. Okay? So it is the only dorsally emerging cranial nerve. Okay? So it emerges and exits out the midbrain pontine junction, comes forward, goes through the cavernous sinus, and then enters the eyeball through the superior orbital fissure. Okay, the cavernous sinus is kind of like a black box right here. We'll talk about it in a little bit. Alright, so it emerges the brainstem dorsally at the midbrain pontine junction, so where the midbrain and the pons connect to each other. That's where it leaves. And it travels through the cavernous sinus. You'll learn why that's important in a little while. And then it enters the superior orbital fissure to get to the orbit, like the eye cavity. When it gets there, it goes directly to the superior oblique and synapses there. Okay. Clinically, there's two things important clinically, and they're both related to injury. Okay? And so there's two weird things about the trochlear nerve. One is that it's the only nerve that comes from the back of the brainstem. The other one is this. brainstem, and this is the middle. So pretend like this is the same view of the spinal cord that I normally draw. It looks like this, right? So this is a cross section through the spinal cord. This is a cross section through the brainstem. Okay. So the important thing you need to know about it is also the only cranial nerve whose nucleus is on the opposite side of the body from the nerve. So the right, so this is right and this is left. The right nucleus gives you your left cranial nerve, and your left, let me do it a different color. Your left nucleus gives you your right cranial nerve. Okay, does that make sense? I'm going to say it again. So, the nucleus inside the brainstem, on one side, sends its nerve to the opposite side. Every other cranial nerve, the nucleus on its side controls the nerve on its side. Okay? So why is this important? Because if you have an injury that damages the nucleus, okay, which would be like most common thing would be like a stroke, like a vascular injury. So if you have a stroke on the right side and you knock out that nucleus, which superior oblique is going to be non-functional? The left. Absolutely. So if you have a nucleus injury, the opposite nerve is affected. Okay? But if you have a nerve injury, the same side is affected. So let's say we've got a tumor that's growing on the left side, and that tumor is pressing on my left trochlear nerve. Which superior oblique doesn't work? The left. Again, a brainstem injury to the nucleus affects the opposite eye, the opposite superior oblique. An injury to the nerve affects the same side, superior oblique. Okay? It doesn't even matter how close it is. If it's not the nucleus, if it's any of the fibers leaving the brainstem, it's going to be the same side. It doesn't matter where along the path it is. So any injury to the nerve itself is going to affect the same side. The term that we use for that is ipsilateral. Ipsi, same laterality, same side. If it's the opposite side, the term we use is contralateral. Okay? So a nucleus is a contralateral injury. The nerve is an ipsilateral injury. Okay? Deficit. Sorry, she used deficit instead of injury. Okay, does that make sense? Everybody understand why that's important?
So is the crossing over occurring like in the brain?
In the brainstem. So it kind of decussates is the word. It decussates. And when it leaves, it goes like that.
Yeah.
Nucleus is
Wait.
Yep. All right.
Because if you were damage right here on your
Again,
side.
testing. Refer to our chart friends. The only thing you do is ask them to add up the eye and look down. Okay, so that's 4.
So the injury is just to that nerve or to that nucleus.
Yeah, the injury, just 2 injuries you need to know. Injury to the nuclei, injury to the nerve.
How do you injure the nuclei? Just
So a brainstem injury like a stroke would be the most common thing. So something that would lose blood supply to that nucleus.
I was waiting for it. Do it fast. Tell me that. It's been a long day.
ever read this in a question stem, it's a dead giveaway that it's a trochlear nerve, okay? What the patient does is, so when you lose the superior oblique, you have unopposed action of the inferior oblique, okay? So the eye that is affected looks out and over. So it elevates and extorts, okay? It elevates and extorts. So elevation up and it extorts, so it looks outward. So it's looking like it's doing what my hand is doing. So like that's the direction the eye is looking. Okay, so if you read this in a stem, it's a trochlear injury. Because that one eye is like off axis and looking over here, the patient has really, really bad double vision because it's like looking at things in like disconjugation, right? So what happens is, without even knowing it, that patient is going to tilt their head to the uninjured side. So let me see if I can make it make sense for you. If this eye, so pretend my hands are my direction of gaze. So if this is my injury and I'm looking over here, and this eye is good and it's looking straight, what happens is, this is injury. What happens is the patient tilts their head to the good side, because when you tilt your head and you keep this eye straight, now inside my eye, like inside the orbit, my eye is now actually parallel in the same visual field. So if I move and look, everywhere I look, my eyes are looking at the same thing. So they get rid of their double vision on their own by tilting their head. So if you ever read that in a question stem, the patient says that they have double vision, but if they tilt their head, their double vision goes away. It's a trochlear nerve injury.
But not all double visions are trochlear.
Not all double visions are trochlear nerve, but that particular type is. So their head tilts to the unopposed side. Does that make sense? That's really hard to explain. When you get into neuroanatomy, they'll actually come in and they'll show you pictures. I remember it very clearly. A picture of this woman that we saw in clinic. It was before my time. But she came in to see the neurologist, and she had her head tilted, and she was complaining of some vision issues. And he was like, "Do you know your head's tilted?" And she was like, "What are you talking about?" He was like, "But your head's tilted, like you're tilting your head." And she was like, "No, I'm not." They do it without even thinking because it fixes it. And so he asked her to pull up like pictures of herself, and for years, in all of her pictures, she's like this. He'll show you, and he actually has the pictures of her. Like he got her permission to use her pictures. So it shows pictures like from years of like her in pictures with her family, and she's always like this. I guess, like when you have families that have like weird things, they just are normal to you. You're like, oh, that's Aunt Nellie with her head tilted. But it's really funny because it's real. Like it really happens. Y'all know what I'm talking about. Everybody's got that weird family member that does that thing. Like I have that weird real. Alright. Alright, so we're gonna do 6 and then we're gonna take a break and we'll come back and do 5. Okay. 6 is really short, like 4. Alright, 6, name? Abducens. Motor, sensory, red. Motor only. Fibers. GSEs, what are they doing? This is motor. Lateral. Good, to the lateral rectus. Good. Foramen.
Superior orbital fissure.
Good, superior orbital fissure. Good. So this one. The abducens nuclei is going to send its fibers out, and they're going to exit the brainstem at the pontomedullary junction, so the junction of the pons in the medulla. It's going to exit out there. It's going to travel in the cavernous sinus, and it's going to enter the orbit through the superior orbital fissure. And when it gets there, it's going to synapse
through?
It goes through the cavernous sinus. I keep saying syndrome. Cavernous sinus.
The pons and the G.
Oh, I'm sorry. It exits at the pontomedullary junction. So the junction of the pons and the medulla. So it exits at the pontomedullary junction, goes through the cavernous sinus, and then enters the orbit through the superior orbital fissure. Yes?
Was that where the trochlear nerve exited to?
No, it's midbrain pontine. So it's up here. So midbrain pontine, pontomedullary.
But it's on the back, right?
Yeah, it's on the back. Yeah. Okay? So, it's going to the lateral rectus. Alright? Clinically, we are going to wait and talk about the clinical thing when we get to the 5th cranial nerve, and you'll understand why. But I want you to put a star, and I want you to write this. Cavernous sinus syndrome. We'll talk about it after the break. But cavernous sinus syndrome most commonly affects cranial nerve 6. We'll talk about exactly what that is in just a little bit. Okay. Ooh, another important thing about 6 is when it leaves down here at the pontomedullary junction, it actually is going to pierce through at an area on the skull called the clivus. Does everybody know what that is? It's like that smooth area leading upward from the foramen magnum. And it's going to pierce the dura at the clivus and travel like frontwards. So this is actually a cranial nerve that is fair to test in the skull where they've taken the brain out. Okay? So they might actually tag it down there on the clivus where it's coming through the meninges, like coming through the dura. Okay, there's no other one that does that, so they can actually tag it that way and test you that way. A lot of the other ones are kind of hard to test there, but you can test that one. It's the only one that lives on the clivus. Okay? So the abducen pierces the dura at the clivus and comes up and goes anteriorly. So just remember that for the lab. Okay? Testing, you just tell them to look front and then look to the side. That's the only clinical thing. Yes. So you all take about, make it short so that we can get through the 5th nerve. Take about a 5-minute stretch, walk around outside, clear your brain for a few minutes, then come back. Yes. Refer to the chart, but it's just tell them to look straight and lateral. That's it. It's easy. Make sure you know your Roman numerals, because I missed one of my questions because you had to answer in Roman numerals, and I, for some reason, blanked on the difference between a 9 and an 11. So just make sure that you know your Roman numerals. I looked at it when I got it back, and I was like, are you kidding me? So just know them. I guess I just picked it really fast and wasn't thinking, I don't know what happened. But anyway, so make sure you know them. Don't make a stupid mistake. Okay, so the names, I'm going to refer to them as V1, V2, and V3. Okay, so that's what you're going to hear come out of my mouth. V, obviously meaning the Roman numeral 5, right? And 1, 2, and 3 being the different divisions. So 1 is ophthalmic, 2 is maxillary, 3 is mandibular. Okay, so that's their names. And of course the name of the whole thing is the trigeminal. Tri meaning 3. Gemini, 3. Okay, so motor, sensory, or both? Well, it depends. So all of them are sensory, but only V3 is both. Okay, so they are all sensory, but only V3 is both. Fiber types. So if you look over there, we've got SVEs and GSAs. The A meaning sensory, so GSA is in all 3. So sensory fibers that are GSA in all three divisions. Your motor, which are going to be your SVEs, are only in the third division. Okay? I'll say that again. So sensory in all three, so GSAs in all three. So general tactile sensation in all three. But special motor innervation just in V3. So let's talk about what those fiber types do. So the GSA, so this is sensation, okay? So the fifth cranial nerve is a super important sensory nerve, okay? It does tons of sensation. It does sensation of the entire face, the anterior scalp, the eyes, and the orbital cavity, your nose, your mouth, your perineal sinuses, your teeth, and then a portion of the tympanic membrane and a portion of the dura and some of your cranial fossa. Huge sensory nerve. That's the most important thing you need to know. It basically is doing all of the sensation of the face. Okay. Let me point out a reason why that is really important. Okay? Let's say you knock out your entire cranial nerve 3. Alright? We're back on oculomotor. Let's say you knock out the oculomotor nerve and your eye is just sitting there. It can't do anything except look down and out, right? Because you've got lateral rectus superior oblique. Even though you can't move it very well, if I were to poke you in your eye, can you feel it? Yes. Okay? Those things that we talk about that are only motor, if they are damaged, you are only losing the motor function of that organ, not the sensory function of it. People get confused with that, okay? So just understand that they are very different, okay? Just like 5 does the sensation of the face, motor of the face is cranial nerve 7. So you can knock out the entire cranial nerve 7, and you can't move your face at all on that side, but you can feel everything. So do you understand the importance of knowing why they are different? Okay, so this is just sensation, except this, which we're going to talk about, except your SVE. Okay? Super important sensory nerve that can function alone regardless of motor, the loss of motor function to things. What's your question?
So when you're saying that you have sensation of sinuses, is that like sinus pressure?
Yes. Like, so when you have like a really bad sinus infection, you can actually have pain in your sinuses too. Like you can press on the front of your face and it'll hurt. Yes.
We need to know specifically what branch does innervation to the brain.
I'll point out the only one that you have to know.
Okay.
Somebody have a question? Just kidding. Okay. All right. Super important sensory nerve. Please don't get this confused with motor function. Okay? Just sensation, just sensation, just sensation. All right, until you get to V3. V3 picks up a very particular motor function. It picks up what we've already talked about, that we talked about last time. It picks up innervation of those muscles that came from the first pharyngeal arch. Remember when we talked about that? We said that arch number 1 develops into cranial nerve 5, and with it, the muscles that it gives rise to. And they are the muscles of mastication, so the muscles that allow you to chew, the anterior belly of the digastric, the mylohyoid, and then the tensor tympani and the tensor veli palatini. So it's all those that we talked about that first day that we met, or a couple days ago, whenever that was. The only part of cranial nerve 5 that does motor is V3. only part. Okay? Do not miss a question because you don't understand that. The only motor deficit you'll have is if you lose V3. Otherwise, it's just a sensory deficit. Okay? Alright. Make sure you know particularly this. So if I were to draw a face, so not good at this. Wow, that's pretty bad. Okay.
That's terrifying.
You know, he's got like the hair, and there's like an ear, cheek,
Great job.
and whatever. So it's a face, all right? If you can just remember these three landmarks, it'll help you. If you'll remember the temple, the corner of the eye, the corner of the nose, and the corner of the mouth. Okay? If you connect those dots, that is B2. Looks like L2. It's B2. Temple, corner of the eye, corner of the nose, corner of the mouth. The strip in the middle of the strip that is inside those lines is V2. Everything above it is V1 and everything below it is V3. That's the sensory dermatome of the fifth nerve, okay? Yeah. It's the temple, the corner of the eye. I guess it probably should go not here. Temple, corner of the eye, corner of the nose, corner of the mouth. Essentially, if you just take a line and connect all of those things, that's V2, okay? So it's the temple, the nose, and then your upper lip. All of that little strip is V2. Everything above it is going to be V1, and everything below it is going to be V3. They're not, no, not the whole thing. Don't worry about that, they're not going to get that specific.
Can you do that one more time?
So don't get too caught up in it. Just remember, here to here, and here to here.
B2.
So the part of the nose is going to be shared by 1 and 2. But as long as you understand that lateral strip, the eye itself is V1, and everything from here and down in the chin is V3. Okay? When they give you something, it's going to be obvious. It's going to be like the eye or the chin. Yes?
Does that one mouth do the lip?
It does the upper lip. The upper, not the bottom lip.
What is the nose? That B2 as well?
The nose is actually shared between 1 and 2. The majority of the nose is going to be 2. But like the very top and the inner part of the bridge up there, like on the eye, that's V1. Okay. Again, it's going to be super obvious. It's going to be like the eyeball. Okay? The eyelid. The chin. The upper lip. Okay? Alright? Just make sure you know which one is doing which. Okay? Okay. Foramens. So foramen for ophthalmic is what? The superior orbital fissure. Maxillary. Rotundum. And mandibular. Ovale. This is kind of sexist, but I always remembered I want a man in the Oval Office. That's how I remember the difference.
No, I know, but where's I get the Oval, like, for me, where is it?
Okay, so, I wrote this for myself to remember to tell you something. Alright, don't forget that these are the only two fiber types in cranial nerve 5, right? Just these two. Look at your chart. It's the only ones that have a 5. However, do not forget that you've got GVEs that are postganglionic parasympathetics that are riding branches of cranial nerve 5 to get to their target. They are not part of cranial nerve 5. They are only riding a branch of cranial nerve 5 to get to where they need to go. Okay?
And only the postganglion.
Only the postganglionics. Postganglionic parasympathetics from 3, 7, and 9.
So how would they test it?
They'll give you a question and ask you which of the following fiber types are components of cranial nerve 5, and answer choice will have GVE in it, and it will be their wrong answer choice. But some people will pick it.
But you have GVs riding branches of 5 to get to where they need to go.
That's true. That's true. If you injure the nerve, if you injure the nerve itself, then you're injuring what's riding on it. Just like if I were to slice open your internal carotid artery, you've lost your sympathetics too. Right?
It's the least you
Yeah. But they are not part of cranial nerve 5.
So why did the GVEs of cranial nerve 3, they're actually part of that nerve?
The GVEs are part of the nerve that they came from. So like the only cranial nerves that have GVEs are 3, 7, 9, and 10. Just those. So the parasympathetics that innervate the ciliary muscle are from cranial nerve 3. They are not from cranial nerve 5.
Is it important to pay attention to when other fiber types join it as far as like the injury comes?
Yes. We'll talk about the big ones when we get there. The big ones that you'll be tested on, I'll tell you. Okay, so let's draw out these quickly. All right, so let's start with V1.
Oh, goody. Alright. Let's do this. Kind of. I'm a really bad artist.
She doesn't step on 2 seconds. I'm still struggling to copy her drawing.
Okay, so you all should have seen most of what I'm going to draw. You should have physically seen it in the lab. Okay?
Try to.
So V1, when you removed the orbital plate of the frontal bone, right? When you removed that, you got to see down into the orbit. Okay? When you look down in there, you should have been able to see all 3 of these nerves. Right?
Yeah.
Everybody saw the lacrimal nerve, everyone saw the frontal nerve, and everyone saw the nasociliary nerve. From that aspect, you should see all 3 of them. I promise they're there. If you can't see them on your body, you better find a body that you can. Nasociliary.
The front one is right beside the optic, right?
Yes, and then it runs right on top of the superior rectus.
They said the nasociliary is further down though.
You can still see it from that aspect. You can see all 3 of these from the orbital approach. Like from the, if you take off the orbital plate of the frontal bone, you can see all 3 of them. You might have to move over some muscles and some fat, but you can see all 3 of them. So lacrimal nerve, frontal nerve, and nasociliary nerve.
The frontal nerve is a subset.
Yeah, you need to see an ophthalmologist.
Yes. All 3 of these are the 3 main branches of V1. And then they branch too. We'll talk about them. Okay? So let's talk about them individually. Okay? Lacrimal nerve. Let me ask you a question. If you get this wrong, I'm going to whoop you. Does the lacrimal nerve innervate the lacrimal gland? Does it make the lacrimal gland produce tears?
No.
Because that's a motor function, right? And this is just a sensory nerve. Okay? It does not innervate the gland. It does not innervate the gland. Okay? It is just sensory. It is sensory from the gland. Okay? So if you have conjunctivitis and you've got an infection in your lacrimal gland and it hurts, V1 is telling you that. But because it's watering a whole lot, that has nothing to do with V1. Okay? Okay. Yes?
Is it the gland that's innervated by the parasympathetics from zygomatic-temporal?
Yes, we'll get there when we get to V2, but yes, you are correct. Yes. It is innervated by cranial nerve 7. Okay? The lacrimal nerve does not innervate the gland. It is sensory only. Okay? What it does do is it does carry postganglionic parasympathetics from cranial nerve 7 that are going to innervate the gland. But the lacrimal nerve does not innervate the lacrimal gland from a motor perspective. It has sensory innervation only. Only sensory. Please don't miss that question. I wrote that question. It's on your test. If he chooses it, don't miss it. Okay? Yeah. I'm going to look up who misses that question. If it's any of you. Okay. People miss it every year. It's amazing. It is just sensory. Okay. All right. That's the lacrimal nerve. Going to the lacrimal gland. All right. Frontal nerve. Everybody has seen the frontal nerve, right? From that approach that we talked about, you move the orbital plate of the frontal bone. Okay? It is going to branch.
Frontal's like the first thing.
It's going to branch into your supraorbital and your supratrochlear. I doubt you'll be tested in this, but if you look at a skull, I don't know why, but all skulls do not have the tiny little holes that these little bitty sensory nerves come out of. Some do and some don't. I don't know why. I don't know if it gets plugged up when the skull is like calcifying or what. I don't know. But on some skulls, you'll actually see the little indentation for the supratrochlear, like right underneath like the arch right here. I can't think of what it's called. Supraciliary arch. Okay, so you'll see the little indentation of the supratrochlear and the supraorbital, and then you'll see the supratrochlear has a tiny little hole right above that. Okay, you're probably not going to be tested on that, but if you have a good skull, you can actually see both of those, the indentation and the hole. Okay, they are doing sensory, okay, to the forehead and the top of the orbit. Okay. Nasociliary. I can't even say it enough. Sensory to the eyeball. It is the main sensory nerve to the eyeball. When your eye hurts, that's the nasociliary telling you it hurts. Okay? The nasociliary has branches. Okay? All right. The nasociliary connects to the ciliary ganglia. From the ciliary ganglia, you have the short ciliary nerves, which are doing sensation to the back of the eyeball. What else are they doing? They are carrying your postganglionic parasympathetics from cranial nerve 3 that are innervating the ciliary muscle and the constrictor pupillae. Remember that? Okay. The function of the short ciliary nerves is just sensation to the back of the eyeball. Okay, that's what they're doing. Sensory, 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 sensory. Okay? But they are carrying your GBEs from cranial nerve 3 to their target. Okay? Remember, we drew that when we drew cranial nerve 3.
So it would be a fair question if they're like, okay, if nasal ciliary gets cut, then
Yeah.
technically GBEs and sensory have been
Absolutely.
impeded.
That should make sense to you in your brain, right? So, like, if I chop the short ciliary nerve, I've lost sensation to the back of the eyeball, and I've lost input to the ciliary muscles and the constrictor pupillae, right? Because they're riding it. So, yes, that's a fair question. Just like if I cut, like I told you earlier, if I cut your internal carotid artery, which you would die because you would bleed to death, but if you didn't, if I cut the internal carotid artery, you've lost sympathetic input because they're riding in. It's the same thing.
So the nasociliary nerve there, is that single-ciliary ganglia?
No, it's just touching. The ganglia are like connected to nerves.
And the short ciliary branches are off of the nasociliary?
Yes, they are.
And the GBEs are riding the short ciliary?
The postganglionic parasympathetics, which are GBEs, are riding the short ciliary to get to their target. Correct. People find this incredibly confusing, and I understand why, but make sure you have it right in your brain. They ride it, they're not part of it, they do not do what that nerve is doing. They are only riding that nerve to get to their target. Stop hating me, I see the hate. Okay. Short ciliary. The next one is long ciliary.
Those are branches.
These are branches of the nasociliary nerve.
Did you draw the short ciliary?
These are the short ciliary right here.
Oh, on the ganglia?
Coming off the ganglia.
Okay.
There's more than one. Next you have a long ciliary. Yes?
Long ciliary come off the ganglia as well.
Nope, long ciliary comes off the nasociliary. Don't get too caught up in like semantics of what's branching where. They're not going to make you draw it on the test. Okay? You just got to know where they're coming from. Okay? You don't have to know that it comes 3/4 of the way up on the inside, on the anterior medial aspect. Okay? They don't have to know that. Okay? All right.
Let me see that Dr. Mays.
Mm-hmm.
Okay. 2 more branches. Someone in the lab has these. Yep, somebody's going to cut it. That's what they're going to do. You're right. Someone in the lab has these, okay? These are the anterior and posterior ethmoidal nerves. Someone has them coming off of their nasociliary nerve.
Let's cut them off.
You can actually see them come off the nasociliary and go down into the ethmoid bone. The likelihood of of them tagging it and one of you yanking it off is really high. So they usually don't tag it, but sometimes they will.
Have you seen
Oh yeah. Everyone has it. It just depends on whether or not you cut it. Absolutely. They can only tag it if both of them are there, because otherwise you can't tell which is anterior and posterior. So you will have 2 little tiny nerves coming off the nasociliary going into the ethmoid bone. It's the only 2 that do that. And it just depends on if they've tagged the front one or the back one. It's easy to figure it out, but if you haven't seen it before, you're going to be like, whoa. Okay?
We're the last group too. There may be multiple cross sections on our I'm going to study them pretty good this time.
The nasociliary nerve continues through the orbit and it exits out. When it exits, it becomes the infratrochlear nerve. It's not a branch, it's the same nerve, it changes its name. So when it comes out, it becomes the infratrochlear. Yes. It comes out right underneath the eye.
Okay.
You can see it from the back. That's it.
You probably can't see it from the back. I mean, you might be able to, but you probably can't. They're not going to tag this. They are going to tag another one we're going to talk about in a little bit, but they're not going to tag that one. Okay? Again, every nerve that I have drawn on this board is a sensory nerve. Every one of them is doing a sensation, right? Right.
What is the anterior ethmoid nerve sense?
It's doing sensation right on the inside of the nasal cavity, right when it goes through the ethmoid bone.
So
Okay.
and what center is doing sensations in the back of the eyeball? Both of them, okay.
Okay, B2. Ooh, before we do that. Okay. This is the pituitary. This is let me orient you. This is a cross section through the head. If I took it and I chopped it like this. Okay? So I took the head and I chopped it straight down and I took the face off. So take the face off and now you're looking at my pituitary gland. Okay? On each side of the pituitary gland, you've got a space that's full of venous blood. That space is called the cavernous sinus. So the cavernous sinus is a space that's full of venous blood that flanks both sides of the hypophyseal fossa. Okay? So it's venous blood, so sinuses that are draining from the eye, that are draining from the middle cranial fossa. They're all kind of mixing up there. Okay? Again, so it is on the lateral walls of the sella turcica. Okay? Everybody recognize these words? No. Just trust me. If you are looking at the pituitary and the hypophyseal fossa, the hole that it sits in, the sella turcica is the space. This is on the side. There's a right one and a left one. Okay? Again, we have taken a section like this, so we're looking at it like this. So you're looking at it this way. It runs this way. Okay? We are looking at it in section. Okay? If you're having trouble visualizing it, like look it up in an atlas and like look at the space itself. Okay?
Is this the same cavernous sinus with the internal carotid coming through?
Yes, it is. That's what we're about to talk about. Okay, so cavernous sinus. It is a space full of venous blood that flanks the pituitary gland. Inside that space are important structures. Medial, you have the internal carotid artery. Right next to the internal carotid artery, you have the abducens nerve. Also going through it, you've got the oculomotor nerve, the trochlear nerve, and V1 and V2. you remember how every time I drew one of those nerves earlier, I made a point to say it's going through the cavernous sinus and then it's going to exit out the superior orbital fissure? Okay? That's for a reason. Okay? So all of these nerves pass through the cavernous sinus. Okay? Why is it important? Because if you have an aneurysm of the internal carotid artery, remember I told you an aneurysm is just an outpouching of the vessel wall that's weakened, that presses against things. So if you have an aneurysm of the internal carotid artery, what's it going to press on? The abducens nerve. So that's when I told you we did abducens, and I told you to write cavernous sinus syndrome and there and star it. This is what I'm talking about, okay? So if you've got something going on with your internal carotid artery, the first nerve to be damaged is abducens. If it gets big enough, you'll press all these other ones too. The first one is abducens, okay? So it might not be an internal carotid artery aneurysm. It might be a big old pituitary mass. Anybody here? I mean, it's kind of personal. Anybody have a pituitary mass that you know? Anyone? They're really common. No one. Okay. If you have a pituitary mass, the first nerve to be compromised is cranial nerve 6. Okay? So cavernous sinus syndrome is just anything in a cavernous sinus that shouldn't be there, isn't normal. The most common things are an ICA aneurysm or a pituitary tumor. Okay? The first nerve to be damaged when you have cavernous sinus syndrome is the abducens, and it's because it is the most medially located in the cavernous sinus. Okay? Okay? Before we go to B2, let's talk about something else. Alright, we've talked about a whole lot of things going through the superior orbital fissure, right? A whole lot of things. Okay? If you are to look in the orbit and you are to take out the eyeball, right? So like take your skull, there's no eyeball in it, and you're looking at the orbit, you should see two things in the back of that orbit. Two holes, right? The two holes in the back of the orbit are the optic canal and the superior orbital fissure. Right? Everybody understands. You look through the orbit from the outside, there's no eyeball in there. You see those two holes in the back. And that's what all these nerves are using to get forward, to get to the eye. Okay? In the optic canal, there should be two things. The optic nerve and the ophthalmic artery. Right? Two things in the optic canal. The optic nerve and the ophthalmic artery. So this is, you're looking at the skull frontwards. Look like you're holding the skull in your hand. You're looking at the eyes, but there's no eyes there. So you're looking into the orbit from the outside. So when you look at the back of the orbit, there's two holes. The optic canal and superior orbital fissure. Okay? Okay. Optic canal has an optic nerve and the ophthalmic artery. The superior orbital fissure has a lot of stuff. Okay? One thing it has that we talked about, the first thing is the oculomotor nerve.
These positions are all anatomical, right?
Yes. Okay? Cranial nerve 3. Remember, it has two divisions, a superior and an inferior division. Yes. Hold on. If the optic canal is here, it would be the right eye. It doesn't really matter. Okay. So you got cranial nerve 3.
That's the superior.
Then you've got cranial nerve 6. And you've got the nasociliary, which is a branch of what? V1.
Right.
Okay, so we've got both divisions of the third nerve. We've got the sixth nerve, and then we've got the nasociliary nerve. Above that, you've got the lacrimal and the frontal. And you've got 4. Okay. You don't have to be perfect, just put them up there. Okay. So all of this is going through the superior orbital fissure. 3 in both of its divisions. 6 and 4. And then all 3 divisions of V1. Nasociliary, frontal, and lacrimal. Right? We've already said all of these things go through the superior orbital fissure. Why is this important? Because you're looking in the orbit, and I told you there's no eyeball, right? So, like, let's take the orbit that you have in the lab instead of the skull. So now you've got the orbit, and I've taken the eyeball out, but you've got all your muscles still in there, right? Everybody still has your muscles in there. Those muscles are oriented and attached to one another by little tendons inside the eyeball, right? So over here, you've got your lateral rectus. So your recti are going to form and connect to each other. Okay? And going through that ring has a name. It's called the common tendinous ring. You've got to know what goes through the common tendinous ring. Okay? Going through the common tendinous ring, you have got nasociliary, optic, oculomotor, and abducens. Okay? The way I remember it, Noah, get in the ark. Biblically speaking, Noah, ark. Okay. So, N-O-O-A. It helps me remember what is in the ark. The tendinous arc. Okay? You've got to know what's in it. Nasociliary, optic, oculomotor, and abducens. The other things go through the superior orbital fissure, here, here, and here, but they do not go through the common tendinous ring. There's a high probability you're going to have that question on your test. So we have a big question bank. We pull from hundreds of questions. But there are certain ones that usually end up on there. This is one of them. Okay? Nasociliary, optic, oculomotor, and abducens goes through the common tendinous ring. Okay? We will power through next time, and we will get through V2 and V3. And if I have to meet with you a fourth time, like on Wednesday or so, I can. Y'all have a good Thanksgiving.
Oh, man.
Rest just a little bit.
No, they're not.
We're still in there,
Oh, they are.
His grades were up.